Hello, everybody. I welcome you all to this talk about lasers and energy-based devices in autoimmune disorders. First of all, we know that in connective tissue diseases, we have several changes histologically, mainly the microvascular changes. Sometimes we have pigmentary changes, and we have tissue fibrosis. And luckily, for each of these changes, we have our weapons that we can use to help these patients. But the main concern remains as the photosensitivity of these patients. Would the laser cause their lesions to exacerbate? Well, in the literature, most of the patients are sensitive to ultraviolet light, but few patients are still sensitive to visible light. But we will see the safety profile of all of these lasers. We will start with lupus, with this very nice literature review of the cosmetic treatments of lupus. And in the laser section, we see that we have few patients in each of these lasers, but the champion here is the pulse dye laser with more than 80 patients in 13 different articles. One of them is a randomized controlled trial. So let's have a look on these patients treated all by pulse dye laser for lupus lesions of different types, mainly discoid lupus erythematosus, but all other cutaneous lupus lesions are present. The improvement was seen in almost all patients. And of course, there is a bias of retrospective reporting, but let's look on the prospective studies. Out of 40 patients, almost all patients showed some improvement, which was in some studies, the average was 60 to 70% of improvement. And the parameters used were purpuric or subpurpuric. Most of patients had purpura after each session. And the safety profile, only 10 patients had post-inflammatory hyperpigmentation, which was transitory, and these patients were of dark skin type. No, any patient had exacerbation of his lupus lesion. So it's probably a safe method to treat these patients. We need larger trials, but from these more than 80 patients, we can conclude that it is safe and it can be helpful for these patients. We can see some of the examples in different articles, a nice improvement after pulse dye laser with minimal scars left. And here another case with a closer view in another article with a complete improvement and remaining mild pigmentation. A third case with a complete improvement without scar of a facial lesion, and even a pediatric case with a nice result. 4 patients from 4 different articles showing the improvement of the lesions. So what are the points to memorize about the pulse dye laser in lupus? First is that the improvement was mainly of the signs of activity of the lesion, erythema, scaling, and symptoms. But less improvement was seen with the late signs, with scarring, atrophy. These lesions improved less well, or even some of the lesions didn't improve. So when you are going to treat with a laser, treat early to get this benefit. And remember that this benefit is not only cosmetic, but also it can stop the progression and prevent the scarring. 3 out of the studies mentioned in the literature have done biopsies before and after, and all of these studies have shown some benefit concerning the cellular infiltrate. This randomized controlled trial, they have done 4 biopsies before the laser and 4 weeks after the laser for 4 patients, as I said, and there was significant reduction of lymphocytic infiltrate and also of the deposition of mucin, and there was a reduction also in pro-inflammatory cytokines leading to lupus lesions. So there is not only a cosmetic improvement, but there is a pathophysiologic improvement with pulse dye laser, but it is an adjuvant treatment. Remember, medical treatments are always the first line. Then dermatomyositis, much less reports and articles about laser treatment, but we have 2 patients with a successful treatment of the erythema with pulse dye laser, and 1 patient with 70% improvement of guttrum papules, again with pulse dye laser. In scleroderma, we have different signs and we can use different lasers. For the skin sclerosis leading to microstomia, we have the intense pulse light, which showed significant improvement and a gain of 4 millimeters of the mouth opening on 13 patients. Pulsed CO2 laser on 4 patients only have shown a gain of 8 millimeters and increased lip flexibility. So still we need more publishes, but they seem to be beneficial for these patients. Maybe also ablative and non-ablative fractional lasers for this indication. For telangiectasia, both PDL and IPL were effective, but in this randomized control trial on 19 patients, PDL was more effective than IPL, both on photographic scores and dermoscopic scores. And for calcinosis, we can always use the surgical CO2 laser to remove the calcinosis in Scleroderma, and even in Dermatomyositis, there are some reports. Then going to the Morphea, we know that ultraviolet light, maybe UVA, was helpful for these patients. And in this randomized control trial comparing fractional laser to ultraviolet A on 21 patients, the fractional laser was highly effective and more effective with a significant statistical difference compared to ultraviolet A on all scores, in clinical scores, in patient satisfaction, and even histologically in the biopsy, we have better collagen homogenization. We can see in this example the improvement of pigmentation, but also of erythema, and even they mentioned that the texture of the skin was improved. So we can use fractional laser for these patients, and even contractures around the joints, fractional laser can be of help. But still we need more studies. Excimer laser also have shown in few patients to be beneficial for Morphia. Then finishing with alopecia areata. Alopecia areata, our first treatment is always intraregional Kinocort. Sometimes we use DPCP or minoxidil, fractional laser, but we are using excimer laser for these patients, and it is helpful. And the literature came with this recent meta-analysis containing 4 randomized controlled trials with a total of more than 100 patients or patches. And there was a very significant difference towards in favor of the excimer laser with 66% improvement. And excimer lamp also have shown comparative results in treating vitiligo, but also here in alopecia areata, excimer lamp has shown in this trial on 34 patients. They compared the sides of each patch, one side minoxidil only, the other side minoxidil with excimer lamp, and excimer lamp was superior in terms of hair number and also hair diameter. Here we can see some examples, a clinical example, and clearly we have the excimer lamp side is better than the other side, although minoxidil was used on the whole patch. And here dermoscopic pictures showing the same improvement. So take-home messages. Medical treatment comes first, and laser is an adjuvant treatment. It's not the main treatment. Then in connective tissue diseases, we have microvascular changes, and pulse dye laser has proven to be effective for these changes and to decrease the lymphocytic infiltrate. In skin sclerosis, both fractional laser and pulsed CO2 laser have shown in few reports to be beneficial. And I guess, as we have seen in scars, in treating scars, non-ablative fractional laser can be of help, but it's not yet, we don't have reports yet about this laser. And the most important message is that much is done, but unfortunately little is reported. I know most of you laser experts have some of these patients with benefit of the laser, but the literature needs more publishes and more trials. And I finish with a big thank you to the ESLD, European Society of Laser and Energy-Based Devices, for their continuous support, very effective and very nice bibliographies and websites. And also a big thank to the French group of Laser for their highly appreciated collaboration and help. Thank you very much.